Okay, let's talk about the maternal physiology from Williams 26th editions. Uh, the uterus. Plus this uterus, what are the changes in the normal physiological family of the uterus? In the non-pregnant woman, the uterus is weight as 70 gram. Okay, first thing is weight is 70 gram. Is almost solid. Okay, the except for a cavity of 10 ml or less. Okay, this cavity it is almost solid organs, but there is some cavity of 10 ml or less. Okay, so in non-pregnant women, the uterus approximately 70 gram. It is a solid structure. It is less than 10 mm. It is except for the cavity of 10 mm or less. During the pregnancy, the uterus is transferred into a thin walled muscular organ. Okay, so during pregnancy, what happened? What are the changes? The uterus is transferred to a thin walled muscular organ of sufficient capacity so that it can accommodate the fetus and placenta and the amniotic fluid. Okay, the total volume of the content of the atom of average 5 liter. The total volume at top is 5 liter, but maybe 20 liter or more. Thus, by the end of the pregnancy, the uterus achieve a capacity of 5,500 to 1,000 times of the pregnancy, non-pregnant uterus. So, the corresponding increase in the uterine weight is such that by term organ by nearly 1100 grams. From 70 gram, it is increased to 1100 gram. Okay. Then uterine hypertrophy, that is any early uterine hypertrophy that occur in early in pregnancy, probably stimulated by the action of the estrogen, perhaps the progesterone also. This similar uterine changes can be observed in the ectopic pregnancy also. But after approximately 12 weeks of the gestation, the uterine growth is related predominantly to pressure exerted by the fetus expanding product of conception. So initially the hypertrophic changes is due to hormonal stimulation. Initially hypertrophy is due to hormone like estrogen, sometimes perhaps progesterone also. But the similar change can be observed also in the ectopic pregnancy. But after approximately 12 weeks, after 12 weeks, the uterine growth is relatively predominantly because of the pressure that is exerted by the expanding product of conception. Okay, within the uterus, the enlargement is most marked in the fundus. So fundus is more enlarged than compared to the other body or lower part of the cervix. The extent of the uterine hypertrophy also influence the position of the placenta. So how the uterine hypertrophy is also dependent on the position of the placenta. Namely, the myometrium surrounding the placental side grow more rapidly than the rest. The myometrium surrounding the placental side grow more rapidly. So, surrounding the placental side, myometrium grow more rapidly than the other structure, other myometrium. During pregnancy, the uterine enlargement involves the stretching, marked hypertrophy of muscle cells, whereas the production of the new myocyte is limited. There is stretching, there is hypertrophy, but production of myocyte, new myocyte is production is very limited. The fibrous tissue also accumulates, particularly in the external muscles layer, together with considerable rise in the elastic tissue content. The wall of the corpus considerably thicken, strengthen during the first few months of the pregnancy, but then gradually it is thin. Okay, so the fibrous tissue also accumulates, particularly in the external muscle layer, together with considerable rise in the elastic content. The wall of the corpus considerably thicken and strengthen during the first few months of the pregnancy, then gradually thin. By term, the diameter is only 1 to 2 centimeter thick. The fetus usually can be palpated through the soft, readily indentable uterine wall. Uterine musculature during pregnancy is arranged in three strata. First is outer hood-like layer, which is over the fundus, extending the various ligaments. The middle layer is dense hook network muscle fiber, perforated in all directions by blood vessels. The last in the internal layer, the sphincter-like fiber around the fallopian tube orifice and the internal cervical os. Okay, so there is three outer inner. There's the middle is layer, the perforated by blood vessels. Most of the uterine is formed by the middle layer. Here each myocyte is double cup so that interlacing any two cells forms a figure of 8. The crucial arrangement permits the myocyte to contract after the delivery, constantly penetrating the vessel, halt bleeding. Uterine shape and position. The first few weeks, the uterus maintains its original pyriform or sphere shape, but as the pregnancy advances, the corpus and fundus become globular, almost spherical by 12 weeks of gestation. Subsequently, the organ grows more rapidly in the length then in width become ovoid. By the end of the 12 weeks, the enlarged uterus extends out of the pelvis. Okay, with growth, it contracts anterabdominal, displaces the intestine laterally and superiorly, ultimately reaches almost to the liver. As the uterus grows, it ascends and uterus usually rotates to the right side. Then dexterity likely caused by the rectosigmoid on the left side of the pelvis. because of rectus sigmoid on the left side of the pelvis. So uterus rotates more toward the right side. As the uterus rise, the tension is excited the broad and round leg. With the pregnant woman standing on the longitudinal axis, the uterus corresponds to the extension of the pelvic inlet axis. The abdominal wall support the uterus maintain the axis. Unless the wall is relaxed, when the pregnant woman lies supine, the uterus fall back to the rest of the body. Column adjacent blood vessel. Uterine contract. Beginning the early pregnancy, the uterus contract irregularly. This may perceived by mild cramps. During the second trimester, these contractions can be detected by bimanual examination. Braxton Hicks is the first brought attention to this contraction, which now bears his name. This appear unpredictably, sporadically. Their intensity vary between the 5 to 25 mmHg prices. Until near term, the Braxton Hicks contractions are infrequent, but their number arise during the last week 7 2. At this time, the uterus may contract often every 10 to 20 minutes with some degree of rhythmicity. Correspondingly, uterine contract electrical activity is low, uncoordinated early in the gestational, but becomes progressively more intense synchronized by the term. This synchronized is developed twice as fast in multiparous compared to the nulliparous. Letting pregnancy is going to may cause some discomfort and accounts so-called false labor. Uteroplacental blood flow. The delivery, most of the substances essential for fetal and placental growth. Metabolism and overstimulation require placental intimate space to adequately perfuse. The placental perfusion depends on the total uterine blood flow, but simultaneously measurement of uterine, ovarian, and uterine vessel not yet possible. Angiography also. For this measure, early result using 4-dimensional Doppler ultrasound intervenes the uterine artery shows progressive increase in the uteroplacental blood flow during pregnancy. The flow rate is approximately 450 ml per minute in the mid trimester to nearly 500 to 750 ml at 36 of gestational. Remember, this question has been repeatedly asking in the NEET SS examinations, also in the usually in the SR examinations also. So you remember this thing, the rate of flow to the per minute, how many blood flow to the uterus is 450 ml per minute in the mid trimester. In the nearly term, 36 it is approximately 500 to 750 ml per minute. Okay. These measurements similar to flow estimates ascertained indirectly using clearance rate of understand and Gen 30. These values are mirror order. Okay. Logically, such massively increased uteroplacental require adaptation to the uterine vein as well as the resulting increased venous caliber distance can result in uterine vein varices rarely mere of just. As noted, first animal study, tetanic contraction really precipitated following the uterine blood flow. In human 3D Doppler has been demonstrated to reduce uterine blood during contraction, usually similar technique resistance. Then uteroplacental blood regulation. The vessels that supply the uterine corpus widen, elongate, it preserve to their contractile functions. As an exception, the spiral artery, which directly supply the placenta, vascular but completely lose contractility. The presumably stem endovascular tropicalized inversion, which destroy the intermittent vascular limits. This vasodilatation allows maternal placental blood flow to progressively rise during gestations. Given that the blood flow increased roughly to the fourth power of the radius of the vessels, small widening of the vessels diameter results in a tremendous augmentation of the blood flow. The artery diameter, okay. The downstream fall in the vascular resistance is another key factor of the accelerated flow. Okay, the nitric acid is a potent vasodilator play a critical role in regulating the process. It is endothelial nitric oxide synthesis and nitric acid production augmented by endothelial shear stress. Several hormone growth of factors also that control the nitric acid synthesis. The factors include estrogen, progesterone, activin, placental growth factor, vascular endothelial growth factor, which is the promoter of angiogenesis. VAGF, PAGF, PLGF. These are the promoter of angiogenesis. The importance aside VAGF, PLGF signaling attenuated in response to excess placental secretion, soluble receptors, soluble FMS like tyrosine kinase 1. This signal is attenuated by the SFLT1 like molecules. It will decrease the VEGF and placental growth factor, that is it will act like an anti-angiogenic. So an elevated maternal SFLT inactivate the lowering the circulating PLGF and VEGF is an important in preeclampsia pathogenesis. Normal pregnancy is also carried as the vascular refraction to the pressure effect infusion by angiotensin 2. This raises intraperitoneal blood flow. This raises normally also characterized vascular. What happened? The vascular refractiveness to the pressure effect of the infusion angiotensin 2. Normal pregnancy, their refractiveness to the angiotensin 2. That will raise the intraperitoneal blood flow. Other factors that document the intraperitoneal blood flow include relaxins, certain adipocytokinins, kemerin, secreted to the cerebral tissue, including the placental. Its concentration rises in as gestational advance serves as human umbilical endothelial nitric oxide this activity. Another adipocytokine visfatin raise VEGF secretion and VEGF receptor 2 expression in epithelial cells derived from the placental amnion. Other adipocytokine like leptin resisting adiponectin alliance, umbilical bond, endothelial cell proliferation. Last, certain microRNA sciences, vascular endothelium, cervix. As early as 1 month after conception, the cervix begin to soften and gain bluish stones. The changes result from increased vascularity, edema of the entire cervix, from alteration of the collagen network from the hypertrophy and hyperplasia of cervical gland. Although the cervix contains a small amount of smooth muscle cell, the major component is connective tissue. The rearrangement of the collagen-rich tissue at the cervix retains in the pregnancy until term. The dilatation, delivery, postpartum repair, reconstruction, formative substance of cell pregnancy. Cervical ripening involves the connective tissue remodeling, lower collagen, protocol can consider as the water. The cervical gland undergo marked proliferation, and by the end of the pregnancy, they occupy up to one half of the entire cervical mass. This normal pregnancy induced changes from an extension of eversion. Okay. The proliferating columnar, what is eversion? This proliferating columnar endocervical gland onto the ectocervical portion. So the endocervical gland, the columnar gland, it is come out of the towards the ectocervix. The tissue of red and velvety, and it bleeds even with minor trauma, since such as pap space training also. The endocervical mucosal cell produce copious amount of tenacious mucus that obstruct the cervical canal soon after the conceptions. The mucus is rich in immunoglobulin. Cytokines may act as immunological barrier to protect uterine content against infections. At labor onset, if not before, the mucus plug, not be, labor onset, if not before, this mucus plug is expelled, resulting bloody sore. Moreover, the cervical mucus constitution changes during pregnancy, specifically in most pregnant women as a result of progesterone. When cervical mucus is spread dried and glassite, it shows a poor crystallization and termed as beading. In some gravida, the result of amniotic fluid leakage or arboration, ice-like crystals called Farnic pattern is seen microscopically. Histologically, basal cells near the stomach junction can be prominent in size, shape, staining, quality, and frequency. The changes are considered to be estrogen induced. In addition, pregnancy is associated with both endocervical and hyperplasia, hypersecretory appearance, Aries stellar reactions, endocervical gland, hyperplasia, and hypersecretion. The cyclic change make differentiating this from typical and truly atypical endocervical participants. Ovaries. Ovulation occurs during pregnancy. Maturation of new follicle is suspended. The single corpus luteum functions maximally during the first 6 to 7 weeks of pregnancy. Then 4 to 5 weeks of postpartum. Thereafter, it contributes relatively little to progesterone production. The surgical removal of the corpus luteum before 7 weeks from rapid fall in maternal serum progesterone level, spontaneous abortion will occur. In this case, the exogenous progesterone necessary for pregnancy maintenance until placental function has to be sufficient. After 7 weeks, corpus luteum accession adrenal doesn't cause abortion. Extra-uterine testicular reactions just beneath the ovarian surface is common in pregnancy. After the cesarean delivery, these appear as slightly elevated clear blister patches that bleed easily, may first class. They resemble placebo lesions. Similar testicular reaction on the uterine serous other pelvic exterior organ also occur. This area arises from the syllabus. So this is a progesterone stimulated endometrioma. Enormous caliber of the ovarian veins view cesarean delivery startling. Relaxing the protein hormone is secreted the corpus luteum, decidua, and the placenta in response to similar to the HSG. Relaxing also the brain, heart, kidney. It is mentioned here because the secretion of the corpus luteum are remotely protected from tissue accommodation level. Relaxing also appear important in initiating augmentation and hemodynamics. The collecting cyst. When an hypertension, reproducts corrected physiological follicle, bilateral cystic ovary variable enlarged, the reaction is linked to the MAC elevation of SCG level. The pelvis is found frequently gestational trophus disease. There may also represent the placenta that occur with the diabetes dehydrogenation, multiple gestation also. Diabetes, multiple gestation, placenta convert to diabetes.